Good evening, everyone. So we are back on behalf of Sir H.N. Reliance Foundation Hospital, Department of Infectious Disease and Critical Care Medicine. We thought that this would be a excellent topic on the backdrop of an outbreak and unusual higher incidence of Guillain-Barré syndrome happening in multiple places, particularly certain places of Maharashtra and also different other places in India itself. And as it more unfortunately happened in Pune, so we thought that we would like to hear from the experts, scientists, epidemiologists, critical care physicians, neurologists, and infectious disease specialists from that very region who sort of fought off and still fighting with the unusual occurrences and higher incidences of Guillain-Barré itself. And so we have an excellent mix-up of different aspects who have treated, dealt, investigated, and tried to find out the root cause of the overall the disease process itself, and we will deal with certain this aspects of it. So I would invite Dr. Vasant Nagvekar sir to introduce our faculty today, and then he will moderate. I will try to support him in between. So Dr. Vasant Nagvekar, you all know, he is the director of clinical infectious disease of Sir H.N. Reliance Foundation Hospital, and also a senior consultant in Lilavati Hospital, Mumbai. And he is also the present General Secretary for Clinical Infectious Disease Society of India. So Vasant sir would be introducing the faculty, and then we will have a small presentation. I will tell what about that, a very small presentation, which will set the ball rolling, and then we'll take up the questions itself. We have kept it as an open Zoom forum so that many people can join, and people would be pouring in, I expect. But I would request if you have certain questions, the audience itself, kindly put it into the chat box or raise your hands. We will try to accommodate your questions itself. So over to you, Vasant sir.
Thanks, Arindam. Good evening, everybody, and it's a pleasure speaking to all of you and on a very important topic of Guillain-Barré Syndrome outbreak, which is happening specifically in Pune, Mumbai, and we have all the experts from Pune Dinanath Mangeshkar Hospital, which is catering majority of these patients. And to answer all these queries, we have the esteemed faculty. The first one I would say is Dr. Vijay P. Bondre. He's a scientist F and a group leader encephalitis group from ICMR National Institute of Virology, Pune. Then we have Dr. B.V. Tandale, who is scientist G, who is an epidemiologist, ICMR NIV Pune again. Then we have Dr. Bharat Purandare, who is a friend of mine and ID consultant at Dinanath Mangeshkar Hospital, Pune. We have Dr. Rahul Kulkarni, who is a consultant neurologist again at Dinanath Mangeshkar Hospital, Pune. We have Dr. Shripat Pujari, who is again a senior neurologist and a consultant at Dinanath Mangeshkar Hospital, Pune. We have microbiologist Dr. Romika Daura, again from Dinanath Mangeshkar Hospital, Pune. We'll be having Dr. Sameer Jog. Has he joined? I don't know. Dr. Sameer Jog is a senior intensivist and again from Dinanath Mangeshkar Hospital, Pune. So we have majority of the faculty from Dinanath Mangeshkar Hospital, Pune, and then we have Dr. Rahul Pandit, who is the chair and director of critical care medicine at H.N. Reliance Hospital. And also we'll be having Dr. Gafur, who is a senior ID consultant from Apollo Hospital, Chennai. So I think this is the esteemed faculty which we have. And Dr. Parikshit Prayag would be joining later on. He said he's slightly caught up, so we'll be joining later on. So I think this is the faculty is extremely extraordinary and who has dealt in depth about these patients, who handled these patients in last, I think, 1.5 to 2 months where they've been seeing. I hand it over to you, Arindam, for the next session. Thank you.
We have a very quick small presentation by Dr. Parth Shah. We thought that we should give a backdrop of the main villain itself, the offending agent, which is supposedly the organism behind the overall higher incidences. I won't say it in an outbreak itself. And then we will obviously look into the other offenders too. So Dr. Parth Shah, who is working with as a fellow and working with Dr. Vasan Nagvekar sir, he's going to give a very quick presentation on Campylobacter species and its unique relationship with Guillain-Barré syndrome. And then we'll start taking questions and we'll discuss amongst all the faculty itself. Parth, over to you.
Thank you, sir. Good evening, everyone. We'll start the lecture. So, the basics about Campylobacter species and its association with GBS. Uh, so, over last 2 decades, our understanding with the role of Campylobacter jejuni as a subspecies jejuni has an important correlation with uh, GBS has understanding has improved, and since the eradication of polio in the most part of the world, GBS has become as the most important cause of acute flaccid paralysis. The outbreaks of GBS are rare but have been reported. So the first outbreak in 1978 of gastroenteritis suffering almost 5,000 people caused by contaminated water in Jordan. Almost 16 patients developed GBS, and out of that, around 8 to 24 days after the onset of diarrhea, they experienced this flaccid paralysis. At that time, the idea of some viral or bacterial post enteritis flaccid paralysis was thought of. So Campylobacter jejuni causes GBS is the definitive evidence is still awaited. Several lines of evidence support this hypothesis by the thought of antigenic mimicry, that is autoimmune mediated attack on the host nerve tissues. Some of the GBS patients have anti-ganglioside antibodies, and some of them have anti-LPS, that is the gram-negative Campylobacter jejuni cell wall or organisms cell wall antibodies, which is associated in GBS, has been detected. Patients who have anti-ganglioside antibodies like structures and ganglioside moieties are present in the relevant sites of the nerve fibers. So there is an antigenic mimicry, which is presumed to be a pathogenesis for GBS. So this is the slide which shows various virulence factor. So we can see this gram-negative bacilli of Campylobacter, which has two flagellae on the both the poles of the bacteria, which helps this bacteria to have a corkscrew-like motility. And it first of all, it tries to invade the epithelial cells of the small bubble, and where it breaks the tight junctions between the two cells and enter into the epithelial cells. This translocation and invasion is followed by, so the bacteria has a very good cell membrane which forms a biofilm, and it inhibits the host mechanism to uh, attack or to clear the bacteria. Eventually, this epithelial loss inhibits the cyclic AMP and causes watery diarrhea. And if the invasion persists and it triggers the host immune system further leads to formation of antigenic mimicry, and antibodies which are formed after 2 to 3 weeks leads to GBS like syndrome, which mimics the host nerve tissue. So this so Campylobacter jejuni basically is a zoonotic infection which is predominantly first time observed in chickens. Eventually they found it in the other animals like pet dogs, cats, pigs, and cattle. So this first step is just adhesion and aggregation and microcolony formation, followed by a mature biofilm formation. Majority of patients stays in this part of the disease where just the superficial epithelial membrane is disturbed and they have watery diarrhea. And followed by, if the disease persists and goes in more invasively, it causes mixture with the other local bacteria, that is polymicrobial environment, and initiates the host immune response. So we all are aware about just simple GBS association with Campylobacter, but it is also associated with irritable bowel disease, and almost 20 to 80% of patients are infected with presumed to be infected with Campylobacter jejuni to have IBS-like symptoms. And the possible mechanism is because of the gut dysbiogenesis, which is causing the host and local gut disturbed flora, leading to IBS. So although we are not well defined. Some investigations have reported that GBS association with Campylobacter jejuni may be as severe as it may result into irreversible neurological damage than GBS followed by other putative infections. Of 58 patients which were studied, 10 had serological evidence that recent Campylobacter jejuni infection. Of that, 3% of the patient, 3 patients had severe infections. Severe disease were defined as fulminant disease, which leading to quadriplegia and ventilator dependency within 24 to 48 hours of onset. Campylobacter jejuni causes GBS as is still definitive evidence is lacking. Several lines of evidence supports this hypothesis by the fact that Campylobacter jejuni causes antigenic mimicry because of the autoimmune mediated attack on the host nerve tissue. Some of the GBS patients have antiganglioside antibodies. Some of them have LPS antibodies, which is present in the gram-negative cell wall, which has been isolated in GBS patients to have both these antibodies. Campylobacter, now there are various serotypes of GBS, and there are two major antigenic variation. One is H antigen and one is O antigen. So O antigen has further various subtypes, but the O antigen is very unique to few of the strains, and it is found that O19 is the predominant. So we can see the slide where there are various strains of Campylobacter, but the O19 is the predominant strain leading to GBS like antigenic mimicry, probably because of the O antigen. So the evidence of link between Campylobacter jejuni infection and GBS, almost it's like 100 years from the preceding infectious illness. Mostly it is viral and upper respiratory tract infection has been described in association with GBS. Campylobacter infection was first reported as a potential evidence of GBS in 1982, where a 45 years old man developed GBS after a gastroenteritis, and it was an irreversible damage within 2 weeks of gastroenteral illness caused by Campylobacter jejuni. Shortly after that, several reports have been described that patients who had developed GBS soon after Campylobacter jejuni infection. Now, isolation of this organism. So, stool cultures have been very effective in isolating this organism. So, there are various studies from Thailand where they found out that the excretion of this Campylobacter in the stool was found depending upon the age. So, children of less than 1 year of age, the around average stool excretion was less than 8 days, and some of them, as the age advances, like 5 years, and then the excretion varies to 1 week to 2 weeks. So, by the time patient present to the hospital after 2 weeks for GBS, many of them has stool culture negative. Almost 50% of the patient with Campylobacter has negative stool cultures after 2 weeks of onset of diarrheal disease, which leads to a false negative thought that it may not be related to Campylobacter jejuni. Serological testing, serial duration of Campylobacter in the stool antigen found almost in 16 days of illness because of the 1 to 3 days of 3 weeks of lag time between the infection and the onset of GBS. Many GBS patients with preceding Campylobacter infection have falsely negative stool cultures, as I already discussed. Enzyme-linked immunosorbent assay appears to be the most common method used to measure the antibody in the serum. Immune response to the Campylobacter jejuni is similar of other illness, that is IgG and IgM, which can be detected in the early course of disease in first to 3 to 4 weeks, and it soon declines to the baseline. But IgA levels appears in the serum during the first week, and again it rapidly falls. IgA levels it is a secretory antibody, so it can be easily detected in the stool and the fecal sample of patients, but only during the first week of acute infection. So after this, we'll have some discussion with all our experts and the current recent advances and what they currently see in their practice. Over to you, sir.
Okay, so Vasant sir will start the proceeding. Sir, there had been a little bit of technical glitch. We actually wanted a unlimited number of people to a, but somehow this number had been now capped to 100. It is little unprecedented for us. So some of our panelists who has not joined yet are not being able to join, and I'm getting a multiple messages. I'm trying to solve it out that this 100 capping goes off. So you start the proceeding, sir, and I'm solving the technical glitch.
Right. Okay. So I think my first question will be to the clinicians, Dr. Rahul Kulkarni and Dr. Pujari. I mean, you would have been the key in handling this Guillain-Barré syndrome, and we would like to know the clinical experience from both of you. So, Dr. Pujari and Dr. Kulkarni.
Uh, this particular, every year there is a surge in number of cases, and these are seasonal. Majority of the times during rainy season, and as it was displayed by our speaker, because of multiple viruses as well as this bacteria, Campylobacter jejuni, and certain other organisms. This time, particularly, there are two things. One is a lot of patients in whom Campylobacter jejuni specifically was found as a culprit. And second, it was not so much in rainy, it was in the winter, which is not the usual time by which GI infection related issues really come up that frequently. And the next thing was that there were certain areas in many towns such as Pune, Mumbai, and others where there were more cases that got reported from. Otherwise, the pattern of presentation of patients of GBS, in my opinion, has been by far similar to what would be otherwise in our regular epidemic. I wouldn't say epidemic, regular surges that come. About Campylobacter, as our speaker has rightly said, Campylobacter related GBS are at times severe. There are to classify two types of GBS, demyelinating and axonal. In the demyelinating ones, it's only the myelin, the antigenic substrate is myelin, and the destruction is mainly of it itself. Whereas in axonal, the axons also are attacked. So axonal obviously is more severe and takes longer time to recover. Campylobacter has more stronger association uh, with this axonal type of GBS, and so they were more severe. Some of them had a rapid, what he said as fulminant presentation, and then some of them went on ventilator. So apart from that, I mean, the syndrome with which they present has been the same. It's always called forme fruste, and it has its different ways of presenting, descending, ascending, some with more ocular, some with more bulbar, that is swallowing muscle involvement.
Yeah, thanks, Dr. Sripat. I'd like to go to Dr. Rahul Kulkarni for his thought process and the clinical presentations, what he has seen in the last 1.5 to 2 months.
Right. So in last few weeks, couple of 3 or 4, or maybe couple of months, there have been a sudden increase in the numbers for sure. We looked at our own data that last year we had around 40 patients who were managed in 12 months, but this first couple of months itself we had around 40 odd patients. So the numbers are clearly up. As Dr. Pujari also said, many of these patients had GI symptoms to start with, and then they had this. So it was a diarrheal illness, which was predominant symptom. There are some who had URI symptoms, but predominantly it was diarrheal symptoms. So all the patient had come from same area. As far as clinical features are concerned, we know that there are two major types, AMAN and the AIDP, the demyelinating type. Majority of these patients had AMAN type. So they had acute motor axonal variant. And there were fulminant cases who went on ventilator for within 24 hours and still are being managed in the hospital. There were few mild cases also where patient did not go to ICU. There were moderate cases where patient went to ICU, did not go on ventilator or did not require parenteral feeding with the tube. But they stayed in ICU for a few days and then they improved and subsequently discharged. Interestingly, there are also cases of Miller-Fisher syndrome where patient gets ophthalmoplegia, ataxia, and reflexia, and there are patients who had overlap of Miller-Fisher and GBS. These have all been well described with ganglioside antibodies. We looked at our ganglioside panels in some of our patients, and those who had Miller-Fisher GBS overlap, their ganglioside antibodies were positive. In pure GBS-like presentation, we did not do ganglioside antibody in all, but those who were where we did it, I think it was positive around 60 to 70% patients. The nerve conduction was predominantly axonal. There were few demyelinating patterns. And the CSF was like albinocytological dissociation. There are a few patients where we could find the CSF pleocytosis, but majority the clinical pictures were not different than what one would see in typical textbook picture of routine GBS patient. As far as treatment is concerned, they were managed with the help of either Plex or IVIG, depending on what was the both the options were offered to patient, and it was patient choice and the clinician choice combined, and patients were managed. So the treatment, the clinical presentation was nothing like a routine GBS that a typical neurologist would see in his or her practice. Only thing is these patients come in sudden outbreak. And I remember one day we had 8 admissions in one day of all sorts of patients. So, there was sudden outbreak, but the numbers are going down. The management, the clinical picture is more or less like what one would do in the routine GBS patients.
So how would you clinically keep your suspicion about, because of the varied presentation? Normally, all of us are always used to an ascending paralysis, areflexic pure motor. That is what has been taught in the colleges and books and in our, curriculum. But with these various presentations, which were coming with some of them with cranial nerve palsies or, descending type of paralysis sometimes. So what was the, how would you clinically suspect when these people coming with varied presentation?
The most important feature of GBS is usually weakness. So, someone who comes with weakness, which is sudden in onset, it is not as sudden as what one would get in stroke. So it is little gradual. So morning patient went to office or school, and then by evening he developed weakness in the legs. So that's the usual pattern. The weakness may usually start in legs, proximal as well as distal lower limb, and then may ascend to involve the upper limbs, maybe trunk, and may go up to involve neck and bulbar muscles, etc. So that's the typical presentation. On examination, they will have usual areflexia. The plantars will be either mute or flexor. So there is no evidence to suggest that there is upper motor neuron involvement. Sensory may or may not be impaired. Sensory is not very greatly affected in GBS. Maybe in 15 to 30% patients there may be sensory involvement, but sensory features are not very common in GBS. As you said, there are some who have these variants where they have different presentation. One of the classic known is the Miller-Fisher or Fisher variant, where we get ophthalmoplegia. Again, we can make out that these patients had sudden onset of these symptoms. They also have usual ataxia, and their reflexes are absent. Many of these patients also have weakness. So they have a combination of Miller-Fisher and GBS overlap, and then it's sudden in onset. So basically sudden in onset, no upper motor neuron involvement, not too sudden like what one would get in typical stroke. And then we also look at their potassium and CPKs to make sure that we are not treating hypokalemic patients or maybe someone who has got a muscle disease, etc. So that's usually the way we decide about the patient. We know that in first 24 hours or first even 5 days, the investigations are all negative. So the diagnosis is essentially clinical. It is supplemented sometimes by doing the investigation. Some patient, if we think that there may be a cord involvement or a brainstem involvement, we image this patient. But suspected GBS and imaging coming abnormal is very rarity. Most of the times the diagnosis will be clinical.
Yeah, I think I will welcome Dr. Rahul Pandit, who is the chair and director of critical care medicine at HN Reliant Hospital. Hi, Rahul.
Hi, Vasant. Hi, Arindam.
Yeah. So, Shripad, any other anything you want to add apart from what Dr. Rahul said?
No, perfect. I think that's what he said. Perfect. So as he rightly said, majority present as they start having weakness in the legs and what is into inverted comma called as ascending paralysis. And that is the one that is very popular and taught at the level of MD. But the other less common and rare variants are also described in literature. And because we had a big surge of patients, we saw a varied presentation amongst our group over a short period of time, and that's what has been described. So some of them had the reverse way descending, and some, like Dr. Kulkarni said, eye involvement called Miller-Fisher. Some predominantly began with the swallowing muscle, that is pharyngeal involvement, and some only mainly have facial weakness. So those are the variants, and those are described, although they are less common, as he has rightly pointed out.
Thanks, Shripat. Arindam, I've just discussed with the clinical features. Would you like to ask anything else?
I think I was tempted to ask about the atypical presentations. I think most of them are covered, including both the ascending and descending paralysis could be NA. I would ask Dr. Pandit that one of the major is that what should be a clinician worried of, mostly when there is a quite a progressive ascending paralysis, when we should think of supporting the patient with particularly on the terms of respiratory muscle paralysis.
So thanks, Arindam. I think it is sort of automatically an extension to understand that as soon as you start having a rapidly progressing or even a slowly progressing paralysis, whether it's ascending or descending, as soon as your bulbar muscles become weak, where you are not able to actually keep your secretions under control and follow them, or your respiratory muscles become weak and you start having shallow respiratory breaths, I think that's the time to intervene. Even before that, you can intervene. Typically, what we would do is we would do a single breath count, and a single breath count above 20 is generally on a safer zone. If they can go above 30, that means you are really having a very good single breath count if they are able to do it above 30. Anything below 20, definitely a concern. If they are not able to reach 15, usually they need intubation. And I think the respiratory muscles, you will be able to even visually see them having shallow breaths. You will be able to see them, they are becoming more and more drowsy. If you waited for them to become drowsy, that means you missed the boat because you've allowed the CO2 to climb up. So you need a very high vigilance, a clinical understanding of what is happening, because there is no other way of doing it. You may read the textbooks and they may say write peak flow meter, write expiratory peak flow meter to actually look at the peak flow. They are so weak that many a time these peak flow meters are not good. They are not able to actually do a proper peak flow meter exercise also. So just a single breath count is fine. The second is, of course, swallowing. As soon as you start seeing that they are actually having a pulling of secretions, or they are having a dribbling of saliva, or you start feeling that their saturation is starting to drop down, again, those are the times when you need to actually anticipate that the bulbar weakness has set in, and you need to get into the airway protection mode at that time. Better to be a little bit early than late, because once you aspirate or once you actually have a respiratory arrest, then obviously the focus gets taken away from GBS to actual life-threatening problem, which is your respiratory failure. And quite often then secondary infection sets in, and you may have problems related to the respiratory tract infection rather than the primary problem, which is the GBS and recovery.
So that we can also conclude that there is almost no role of a non-invasive support, if there
Absolutely.
is any support.
I think, no, I completely agree with you. I think this is one condition where non-invasive support is absolutely not indicated. My only submission towards non-invasive support would be in preparation for intubation. If you have a patient who's got a difficult airway or anticipated difficult airway or OSA history, you may actually start them on a pre-oxygenation using high flow nasal cannula. That would be the preferred one as per the difficult intubation algorithm. Or you may sometimes put them on an NIV with 100% FiO2 just to pre-oxygenate them while you're preparing for the intubation over the next 5 to 10 minutes. But ultimately, that is just as a bridge for intubating, and over the next 10 to 15 minutes, you go ahead with an intubation. The beauty of having a high flow nasal cannula is that you can have apneic ventilation continued while you are actually doing the laryngoscopy. So you continue with NIV, you take them on high flow nasal cannula, and then you intubate them. That would probably be the better way to intubate these patients if you suspect a difficult airway. If the airway is suspected, is anticipated to be straightforward, I don't think there is any role of doing anything like this. Just normal oxygenation through a non-rebreather, so that you have a bit of a pre-oxygenation going on, should be more than enough.
Fair enough. Vasant sir, any questions from your end?
I think critical care. I think I think Samir has not been able to join, na, because
No, sir. He's stuck. He's trying to join. He told me he's messaged me that he will join in a bit.
because there are a lot of delegates also wanting to join. So that's it.
That's
Yeah. So I think coming back to Dr. Romika, what was your help or microbiological data when you had these, a lot of these patients coming to, and what has been your observations and, your reports?
Sir, we received around 35 stool samples from patients that were admitted in DMH, and we sent those stool sample to NIV, and 2-3 biofiles were also ordered from patients that got admitted. So that 35 stool sample, the NIV reported like 6 or 7 Campylobacter jejuni on those samples, while around equal number, around 6 or 7 have norovirus also. Though norovirus being calciviridae is not frequently associated with GBS, but NIV has reported around 7 patient norovirus was also isolated, and one throat swab also, tested positive for Mycoplasma pneumoniae also. So most of the patients, they were like positive for Campylobacter jejuni and norovirus, but one patient was positive for Mycoplasma pneumoniae. So maybe the co-infection, or I don't know, but there was a random findings, in our lab. And when we put up biofire of 2-3 patients which were ordered, so Campylobacter jejuni was isolated. Biofire actually doesn't differentiate between jejuni coli and Absaliensis, though it included antigens, the targets for all 3 Campylobacters. But the 2 patients were found to be positive for Campylobacter species in biofire GI panel.
Vasant, you are on mute.
वसंत सर आप म्यूट पे हो.
So just now we just surpassed the, in rainy season and just before winter, we had a lot of dengue and we had a lot of chikungunya, and there are some cases of Zika also being reported in Pune.
Yeah.
So there has been a strong association of dengue, chikungunya. In fact, in HN Reliance also we had a patient with post chikungunya developing a GBS. So any of these, Shripad, Rahul, Bharat, any of your patients who had these tropical illnesses apart from Campylobacter jejuni as a cause of, GBS, because huge patients of chikungunya had this epidemic was more of neurology associated with GBS. So did any of your patients who entered into this GBS epidemic had this tropical?
Not in the present era, of course. These disorders, arboviruses associated neuropathies are well known. We always debate whether these are really post-infectious or para-infectious phenomenon, and there is a lot of doubt. We had reported cases of chikungunya-related peripheral neuropathy long ago with Dr. Tandre was one of our author. This was 2006 that we had reported. Probably one of the first paper of neurology of chikungunya which was described. We also have seen dengue-related GBS many times, and in fact, this also we have reported. The classic presentation of dengue-related neuropathy usually comes with bifacial weakness to start with, and then the motor weakness. The bifacial weakness is starkly high in these patients, and then of course they'll get the limb weakness. So it's a GBS with predominantly bifacial weakness. That's a typical pattern or phenotype of dengue-related GBS that we think is there. Zika neuropathy presenting a GBS, we have not seen. There are lots of papers from Brazil and maybe US also, but in India, at least we had sent Zika in some of our patients and never come positive. And of course, COVID was also known to be associated with GBS. Again, this has been reported from Pune and Mumbai, both the places. So viral related neuropathies are being known. Only thing is, there is always a doubt whether it is a post-infectious phenomenon like what happens in Campylobacter jejuni, or it's a para-infectious phenomenon. And we always debate this, whether it is a para-infection, post-infection. For this chikungunya, we think there are 2 patterns. We had clearly described that there are para-infectious pattern, which are early neuropathies, and post-infectious, which were late neuropathies. But with dengue, we had seen again mostly para-infectious kind of neuropathies. So arboviral neuropathies are well-known entities. In this current epidemic, we have not seen these. Our current outbreak, we have not seen these patients.
Dr. Kulkarni sir, Arindam here, very quickly. Is there any clinical significance of para and post? Can we sort of
para-infectious is supposed to be a hyperimmune kind of reaction, while post-infectious usually is more like a molecular mimicry. The para-infectious are mostly axonal neuropathies. The CSF may sometimes show pleocytosis, while the post-infectious are predominantly demyelinating. Some of them can be axonal also, like GBS. of Aman variant, the CSF would show albuminocytological dissociation. So that's a clinical difference. And as far as treatment options are concerned, we would treat both of them with same ways, but para-infectious will not respond to treatment as good as the post-infectious ones. That's our understanding.
So the prognostically that could be worse or a
That's
response
what we
wise.
think.
Yeah.
Yes, that's what we think, because you have dengue, you have acute dengue which is ongoing, and on top of that you develop neuropathy. These patients who are platelets are low, their hepatitis is ongoing, so these are the patients who are going to do little worse compared to someone who had hemorrhagic, who had URI or maybe GI symptom 2 weeks ago, and then he comes with neuropathy. These are different guys, different patients.
Thanks, sir.
Just before this epidemic, when we had chikungunya where we were seeing neuropathies, some of our chikungunya patients, we found the CSF chikungunya PCR positive. So that supports what Dr. Kulkarni says. It's not very common that it will come positive. But if it comes positive and it's along with the fever, then it's para-infectious, as Dr. Kulkarni says.
Bharat, any comment from you on the tropical illnesses and GBS? Of course, all your patients would be finally go to Shripad or Kulkarni.
Yes, so it was mainly managed by the neurology department. Now, about the patients that we had, most of them had a GI syndrome. And because when you get a tropical syndrome, generally you don't get any localizing symptom. So most of these patients had diarrhea while they were hospitalized or before they were hospitalized. So it was clearly some GI problem which may have caused. The clustering of the cases was also showing the same thing, because they were clustered around both sides of Simvagad Road, predominantly from area of Nare and Dhairi, and around and in Nanded city. So NICD had done a survey of water sources of those areas, and they found that some of the samples were contaminated with Campylobacter jejuni. About the dengue, chikungunya, and Zika, we haven't found any of these illnesses in our patients who have currently admitted with GBS. But as Dr. Romika told, that we had some 9 noroviruses and some 6 Campylobacter. And when we searched literature, we found that it is the Campylobacter which has been most consistently associated with GBS, and nearly 25% of the GBS patients could have Campylobacter infection in the recent past. And out of that, O19 and O41 are the strains which are supposed to be most commonly associated with GBS. Then, contrary to what Dr. Romika said, that norovirus has no association with GBS. In fact, there have been some case reports of norovirus association with GBS, and particularly Miller-Fisher type of variant of GBS is associated with norovirus. So that we found in the literature. However, we cannot 100% surely say that all these patients had Campylobacter or norovirus or mixed infection, because in a large majority of them we couldn't find evidence. Say a few percent of them had this evidence of this infection, because it is mostly post-infectious, and by the time they reach us, the pathogen detection may not be possible by the time they reach us.
So I come to Dr. Tandale and Dr. Bondre. I think your epidemiological survey of this outbreak, which has been going on specifically in Pune, and I think was it to a particular area, or your comments on this, Dr. Tandale and then Dr. Bondre?
Yeah, thank you. We have been actually working very closely with state government, divisional health services, district health services, and also the corporation health authorities. And they had initiated the household surveys for all the households in these affected areas. The first round of survey was initiated on 22nd or 23rd, and this was completed on 31st of January. And the findings of the survey are like only 168 out of, say, 66,000 people had given history of diarrheal illness in last 14 days before the survey date. So as we see this aspect, we really thought of maybe there is something that may have precipitated the GBS cases in the community, because this was very specific clustering happening in these areas. So first few cases I had visited Dinanath Mangeshkar, talked to Dr. Zog and his team. We had internal discussions with all the scientists at NIV. We got through the literature reviews also, that what is expected. in such a scenario. And the most important aspect was that this was clustering reported in a specific area in a specific time point, that we are getting more number of cases that after interaction with the physicians. So what we did is we actually worked with PMOH, PMC MOH officers and discussed the plan. I was part of the state RRT also, and let me give you the data that they have. So the OPD attendance at the PSC, we had gone to the PSC Khadakwasla, which is catering to these most of these villages. With these villages getting into PMC areas now, there is a problem of who will provide the healthcare services, who will provide the water supply and all these issues. So these are administrative issues, but I think these are really important in this scenario to understand how it must be going on there. And there is a well and more than one well, likely possibly just beside the Khadakwasla and below the Khadakwasla dam, where the input water for this well is taken from Khadakwasla itself. There are large pipes that go from Khadakwasla to different parts of city that is not yet in PMC limits. And this is served by the water that is from this reservoir. And the inlet water that comes to the well is not covered. It is again likely to have porosity and likely contamination chances. There are different societies living nearby. And when we visited, actually this chlorination activity has been contracted out. So it is PMC, I think, managing the contracting and monitoring of this activity. So the water sample related activities that they do in that well were inquired, and they actually were not able to support that with their registers and all that. So there is a possibility definitely that some contamination happened in that well, which has, I think, 21 or so submersible pumps. Those lift the water to different societies in that area. Chlorination with bleaching powder was being done. And I think the process that chlorination, there is no filtration, there is no sedimentation, there is no as such water treatment plant as such. So this is kind of a arrangement that villages have been making it and using it for a long time. So the area that we are interested now and understanding this issue is a very small area. It's just 5 by 5 kilometers area, if you see on the map. And this is Kirkatwadi, Nandosi, Nanded Fata, and all these areas, those are adjoining. There is Nanded city also, some cases had reported. Dairi, DSK, and other societies also are reported. So what we did is we actually got into the PSC Khadakwasla MO's interactions, and we actually asked for the December, November, and January months their OPD attendance, which is reflecting that there was definite increase in the second week of January, and we know that the first case got admitted on 9th January. That was maybe a first case after but the onset was on 24th of December. First case had that onset of 24th December. May not be related to this episode again, because we had a larger time period that we had inquired about 6 weeks before GBS development, because that is the longest time that is reported after the antecedent illness, so that GBS development can happen. Most of these cases may happen in 2 to 3 weeks. But in this kind of a setting where outbreak of diarrhea, the outbreak actually got missed, and there was no effort at healthcare services level to understand whether there is an outbreak happening. The outbreak was actually detected after previous cases started reporting from that area. So there is definite antecedent outbreak setting that we are actually investigating by maybe surveying the population to understand the attack rates during the November and December months, and then understand how much increase it has happened in January. So there is a possibility, much likely, that there was a definite contamination and the diarrheal outbreak and other symptoms. I'm just referring to the other symptoms, those are getting reported by clinicians, the ARI and acute febrile illness. These may be part of the sporadic cases that may happen in this area also or otherwise. If you consider the incidence of GBS, it is very less, 1 to 2 per 1 lakh in literature. and AFP surveillance happens in children below 15. And AFP surveillance was able to pick up that increase of GBS cases in that area. Samples were tested in Mumbai also for the children for AFP. Those were negative for polio, and they were again tested for non-polio enteroviruses. We simultaneously tested them for Campylobacter because we have a small bacteriology lab in Pashan campus, and we have enteric viruses group in main campus in nearby Sassoon. So we are getting both positives. And this is puzzling for us because Campylobacter is known to cause and is reported in literature, very common association. And definitely that we are continuing the efforts to understand. The numbers now at the almost maybe 3 + 4 weeks after the investigation started, is that noro positivity is higher. Maybe someone mentioned that even Campylobacter positivity may go down with the period that we may have that the sample collected. So that is one thing that we may be missing some of the Campylobacter cases because the shedding has stopped. But noro, there are two. I think Dr. Jog is not there, but there are definitely some two different types of patients that they were seeing. Some of the patients, those have post-infectious, and another is para-infections. Dr. Rahul Kulkarni also mentioned. So there may be a possibility that we are dealing with two different agents together. Is a mixed outbreak, and we are investigating further. There are definite possibilities that noro, as case reports Dr. Bharat has indicated, we need to look at, and we, as a research question, NIV is doing that. Thank you.
Dr. Bondre, your comments. Thank you,
Yes,
Dr.
sir.
Tandale.
Dr. Tandale has explained all the epidemiological aspects of the disease. And whatever the agents they are known to cause the GBS, we are trying to catch them up in the different clinical samples, whatever we are getting. But invariably, we are getting only the Campylobacter and norovirus. We have tested for all other known like hepatitis, EBV, CMV, chikungunya, but all of them are turning negative. So probably we have to look more detail into the pathology of the norovirus, which could lead to this kind of symptoms.
I would like to ask Dr. Robita, and then I hand it over to Arindam for further discussion. Romika, so as Dr. Parth, my fellow, had said that 50% of the people by 2 weeks, their stool cultures would be negative for Campylobacter jejuni. Of course, norovirus has also been detected in your patients. So, was there any other material like metagenomics or NGS or anything else which, or a PCR based technique, anything which was possibly done to find out whether Campylobacter was there or not? Any, because cultures may come negative of
Yeah, because Campylobacter is a fastidious organism and it requires special conditions to grow. It is thermophilic as well as it requires microaerophilic environment. So it's difficult to grow Campylobacter because it is present in very less quantities as compared to the other fecal microbiota. So this culture of organism is a not very sensitive method. Definitely we can go for multiplex PCR, that is bio5GI panel is available. And there has been a study which has individually identified the performance characteristic of every target of GI target, the GI panel, and they have found that the Campylobacter target, they have a good sensitivity, around 97% sensitivity and 98% specificity for this Campylobacter target in GI panel. So this multiplex PCR is definitely a good answer for quick diagnosis, as well it is very sensitive also.
Vasan, just add a few things, is that okay?
Yeah, Rahul, yes.
So if you look at the literature and over the last 20, 30 years that we have seen in ICU, obviously Campylobacter is the one which is commonly associated, but almost 7-8 viruses which we commonly get infected with are known to actually have patients who have come to us with GBS. And not only that, it may not be just an infectious complication, like Mycoplasma pneumonia also is reported in the literature. Even post-operative patients, sometimes we find no cause at all. So an immune reaction, an aberrant immune reaction to a body could be like any trigger. It need not be just an infective trigger. It could be a non-infective trigger like a surgery as well, burns as well. So we have a lot of ambiguity in understanding the actual nature which causes this trigger. We really don't know that. But I believe that you have an infectious as well as a non-infectious causes. And in infectious, I think viruses are predominantly there, but bacteria can also trigger a similar sort of reaction.
So, one question to our scientist, Dr. Bondre and Dr. Tandale. So, was from our ID consultant from Kerala, and he has asked, is Zika plague reduction neutralization test done in any of the samples which have been tested negative for Campylobacter or noroviruses?
In
that
fact,
are
sir, Vijay sir, just 1 minute before you answer. In fact, I would request our panelist, eminent panelist, because there are myriads of questions, maybe or not all the questions we can take. If they can directly answer certain questions itself. Dr. Romika, Dr. Rahul, all of you, if you can just look into the chat box and answer certain questions. Sorry, sir, Vijay sir, please continue.
Zika investigation by PRNT or IgG is going on, but till now we have not got any more positive cases. 1 to 2 scanty cases are going to come in Pune. So we did not find a lot of cases which are affected by the Zika.
Yeah, so I can confirm that because there are almost 150 plus samples now tested for these patients at NIV Pashan campus, which is the lab diagnostic virology laboratory, which is also the resource center for the virus research diagnostic laboratory network in India. So they have all the protocols and testing ongoing. PCR detection is negative for these most of these patients. For Zika, definitely the convalescent samples will be critical for this aspect because serology needs to be done. And we have a limited number of discharge patients recovery samples, convalescent samples as well. We are processing them for PRNT. We will be planning that.
Wherever the ample amount of the sample was available, that has been started now for the PRNT.
There are no Zika related GBS cases reported from India till date. Not even anywhere from India.
Yeah, Dr. Rahul.
Arindam, over to you.
I have got some 2 cases of EBV and 1 case of CMV in the suspected Zika cases.
I think this is much expected with such a population, huge population in Pune and Mumbai. These are sporadic cases. Let me tell you one more thing that the cluster area that we have investigated the cases, I can give you the numbers also that we have this area that is, we are saying hotspot. Out of say 88 or 90 patients that we are still counting, but the last case happened on 6th February. First case happened on 13th January. That is the period. So this is 3 weeks. And after 6th February, there is no case on the line list from this affected area. So we are almost maybe certain that this area, that's hotspot, has had some water related issue. And we know that what it was. It is already in the news. Water supply, water distribution, quality, monitoring, all these aspects. We are again, we have that the most common reason that we are believing, but there are other things that we need to investigate. You may have seen the food and other practices, animal handlers, all that inquiry is being done as part of a case control study. We have initiated that in this area to understand whether there are any other exposures. You may have seen the chickens coming positive for Campylobacter, but there are many other hosts. I will not conclude this with just doing chickens and understanding that the outbreak and explaining that. So most of the cases and the source of infection really needs further investigations. We are doing our part, and we are doing a case control study also to come up with the exposures and this associated with this. Thank you.
Thank you, Dr. Tandale. There's one question for Romika. Was a serology test being done? And I think there was, yeah. So any serological tests which you had done?
Sir, we didn't do any serology test specific for this Campylobacter, but serology was definitely done to rule out hepatitis A or E, but none of them was found to be positive.
Right.
For the patient, those got admitted in DMH.
Yeah. Arindam, to you, back to you.
Yeah, quick treatment related question, certain things that, and quick fire. I will request our neurology panelist as well as Dr. Dr. Pandit to chip in. So rapid fire, IVIG or Plex, does anyone have a superiority over other?
No, both are equally effective. As Dr. Kulkarni said, it's as per the choice of clinician, uh, patient, and availability of the facilities.
Can they be used one after another if the response are not there?
There is no evidence, scientific evidence, level 1, to say that if one does not cause recovery, then you can use other and that it hastens recovery. So if the recovery is poor, it only means that it's more of an axonal and more severe variant. But then eventually, majority, more than 97% of patients come back to ambulatory life.
Only less than 5% may have a prolonged and sort of a.
Absolutely. Absolutely.
In view of nowadays, both are IVIG and Plex are obviously quite costly in terms of if we go to a resource limited setting. Is there any role of steroids as a poor man's alternative?
The
Again,
trials of steroids are uniformly failed, and steroids can worsen the condition, including because of the infection. So there is no role of steroid at all. Absolutely no role. Usually, one should understand that, you know, in a desperate situation, trying something is going to help. That's not correct. So steroids, there is no evidence at all. Large number of studies have been done in late 20th century. All the trials have failed. So no role of steroids at all.
So rather, it can aggravate the situation, right, sir?
Not aggravate, but you know, it can cause lead to infection. My intensivist colleagues will agree with me that if you give high dose of steroid in these kind of patients, it's going to cause more trouble.
Dr. Pandit, any comment, sir?
Yeah, I think there is no role for steroid. I completely agree with Dr. Kulkarni and Dr. Pujari. Absolutely, it actually would worsen things. It would contribute to infection, and it is not going to add a bit to the treatment at all. So, no role.
Okay.
The only thing about one after the other,
Yes.
I completely agree. Again, no evidence. But if people are mixing it and doing it, please don't do it on the same day. It makes complete wastage of IVIG. If you do it, give a bit of a gap between the two therapies at least. But first of all, you don't need to actually do both the therapies. That's the bottom line.
There was one trial of a second dose of IVIG, which was there about 10 years back. It was thought to be very path-breaking kind of trial, but the trial failed miserably. So there's no role of repeating second dose of IVIG for sure. The combination, the alternate therapy, IVIG followed by Plex or Plex followed by IVIG has been used many times by clinician in way of desperation because, you know, patient is on ventilator, is not recovering, give a trial. But all the patient where it has been used, I don't think there are any good examples where it has really helped. So people use it more of out of desperation rather than by clinical evidence.
Sir, very quickly, Kulkarni ji and Pujari sir, can it relapse or recur?
3% can relapse. 3% can relapse. So recurrent GBS is known. We have had patient who had 3 relapses. At present, in the current epidemic, we have 2 patients who had relapsed GBS. They had GBS. That's a different story, but it's a well-known thing. 3% of GBS can relapse.
And will be the treatment same?
Same.
The treatment is same.
Be same. The recurrence occurs years after the first relapse. So the treatment is essentially same.
Any
So
role?
we had a patient as well last 5 months ago.
Yes.
In fact, one from our profession only, who's gone back to fully functional life, thank God.
Dr. Saab, and yes, it's completely recovered. No, that's why specifically. Yes, Vasant sir.
Any role of rituximab in failed therapies?
Yes.
Again, people have used many therapies, including there are newer agents which have been tried, but you know, there is no data, big data on this. You know, you would treat probably initially with either IVIG or Plex, which will be getting over in a period of say about 7 days. Maybe you will wait for another week or so. So by the time you think of second therapy, you are already in 3rd week probably. So that's where I don't think any drug is going to help. So probably these are the patients where you probably require good nursing care, and we need some drugs which can enhance the axonal damage or maybe enhance the remyelination. There is no point giving immunotherapy because by the time the immune damage has already occurred, the permanent damage has already occurred.
So two interesting question has now cropped in that is there any direct cause of death or death in GBS is mostly due to the complications itself, infectious complications are already relevant.
So GBS per se is because of autoimmune autonomic dysfunctions. You know, some patient can get sudden tachycardia, bradycardia, or hypertension, or even hypothermia also. So that's really a condition where patient can die suddenly because of some tachyarrhythmia or maybe sudden hypotension or hypertension. So that's a rare condition, but it's a well-known thing. So that's the only condition where patient can die because of GBS. The second way he can die because of GBS is, if he's not been intubated at the time and he goes and gets hypoxia, but that should not happen in current medical scenarios.
Any comment, Dr. Pandit and Dr. Pujari?
Yes, I completely agree with Dr. Kulkarni. GBS per se can kill the patient too. Majority of patients having complications of this, usually aspiration infections such as aspiration pneumonia, bed sore, pulmonary embolism, and things like that. Not GBS per se.
Dr.
Dr.
Bharat,
Arindam,
you explained the picture.
GBS becomes a problem when they are in the ICU. So if they don't need ICU, they should never die because of any problems, because they should recover. But once they need ICU, the death is usually because of ICU related complications and problems, which we see often in ICU. So when they come to ICU, it actually becomes a critical care disease with the neurologist on the tap. So neurology input remains crucial in the initial part, and then it's all about nursing, and critical care input when the things go wrong. Otherwise, honestly, if they don't come to ICU, if they are getting better at the ward level or HDU level, then they really should not be dying.
Bharat, your role, I think once the patient gets into infection, I mean, your experience.
So that's the usual scenario in which they'll get eventually tracheostomized and they'll get ventilated, and then they'll get sort of ventilator associated pneumonia or line related infections, and sometimes even going up to C. diff if they are exposed to multiple courses of antibiotics. They already have a Plex catheter in C2, and most of them who have got zero power in spite of Plex and the other modes of treatment land up in infection. So most of the times the problem is the infection, one infection leading to another. And I mean, it's a usual ICU scenario for any patient who's stuck onto ventilator. What happens to these people? We feel sad because they are otherwise preserved and they're quite young. We have got even few pediatric patients also who are stuck on ventilator with zero power. So it's a sad scenario. However, we'll try our best to get them at least out of the infection cycle, get them at least on TPs, on tracheostomy, and as soon as possible get out of the ICU. That's how we do, but nothing like very different from what happens in a chronic ICU patient.
Right, Arindam, anything from your side?
More or less, sir, we have covered up, and also we are now on the time. So I
So
would request,
a couple of
yes, sir.
intensive critical care things which I believe
Yes,
once
sir.
they end up in ICU, which get obviously need to be given core attention, is infection control and nutrition, and of course skin care. I believe that there is a huge amount of deficit which happens in many of the ICUs where, and I'm not talking about big hospitals where tertiary care, quaternary care is happening, but smaller hospitals where the facilities may not be that supportive for these kind of things. There's also an autonomic disturbance which creates sometimes it creates problems with food absorption, constipation, diarrhea. Then often led to a thought process that this food malabsorption is because the patient is not tolerating the feeds. But we've got to think about autonomic disturbance as well as one of the problems. And of course, early infection control measures in these patients are very important because, as Dr. Bharat Purandare said, and Vasant would agree as well, once they get infected, it's very difficult. They're not able to participate in physiotherapy actively. They're not able to cough out secretions. They're completely dependent on us. It's almost like a patient on a atraquarium infusion because they're so weak that it becomes really our care. It is our care which makes a difference in their outcome. And before that, if we can actually get them better before they hit the intensive care in HDU level or ward level, I think the outcome is the best.
And also, sir, I would like you to mention about the early critical care rehab that you have come up with an ECRU unit even.
So
for the rehabilitation?
we have a early critical care rehab in our ICU itself. We have a very supportive and very active rehabilitation department led by Dr. Ashish Contractor, and we have a very enthusiastic team of rehab specialists who come across to ICU. We've set up things in the intensive care where we are able to give them a comprehensive understanding of the need for physiotherapy and rehabilitation, as well as we've got a lot of equipment, including a basketball, a motomed. They are able to actually have a lot of exercise done in the intensive care unit itself. So the need for them to go down for a specialized care is brought down, and we are able to give them care much more than what one would give at a bedside or at a chair side. So we've sort of set up that ICRU unit within our ICU, which is really very helpful for, especially for patients like GBS who would require a lot of rehabilitation before they get back to the community.
Prasanth sir.
Yeah, Arindam. Parth has got a couple of slides just on
Yes.
the part, and then we would like to take expert comments from Dr. Bondre and Dr. Tandale. And then I will, yes. So, Parth, just last two slides of yours, which have been.
He wants to close it on the futuristic note, right?
Yes.
So conclusion and future directions. So we need a additional surveillance to know the better estimate of infections in incidence of GBS and its correlation with the epidemiology of Campylobacter induced GBS. Second is we need to encourage more studies on the host susceptibility to GBS. Why some patients develop GBS and why don't many of them don't go into the complications. Standardized microbiological laboratory procedures are needed to ensure that proper isolation of the Campylobacter strains which are associated with GBS. Serological assays for the diagnosis of Campylobacter jejuni infections need to be standardized and validated. A diagnostic test specific for Campylobacter species is needed since large number of Campylobacter infections are likely to undergo unrecognized. In an animal model for Campylobacter enteritis, with ensuring GBS is urgently needed, there should be a Campylobacter strain bank which establishes which bacterial strain isolates from the patients who develop GBS or the variants can be deposited. These strains should be available for the research in the field. Uh, there is a need for standardized reagents, particularly monoclonal antibodies, that can be used to identify the bacterial epitopes and which can be tested for the ability to react with different neural targets. Better typing systems, that is phenotypical and molecular, is needed, and additional studies on the pathogenesis of the different forms of GBS is needed. Lastly, I would like to welcome you all to our SIDSCon, which is held in the month of September this year, and it's a academic feast for all infectious disease related topics, and it's going to be held in Mumbai in the month of September. Thank you.
Tandale sir wants to say something. Sir, you have to unmute.
Yeah. So thank you all for that very important discussion we had during this outbreak. Yeah, I have some reflections on this, and I seek the input from CIDS, infectious disease experts, neurologists, because we are struggling to actually streamline the testing strategy. So we know that antecedent infections are much likely in 1/3 or so patients. So I request that input, that how do we go about rationalizing the testing, because we are struggling with this, because we are doing dengue, chick, Zika, this all is negative. EBUCM is likely sporadic, but testing needs to be done. We are ruling out that. But in the outbreak setting, and we really need to work with public health, local public health, because we got to know that of that issue only when we saw the clustering happening in that area. So this is an, I think, important aspect that for neurology and infectious disease society and associations to dwell on the clinical algorithm, when to suspect which agent and how to go about testing. So NIV actually request that input from all the experts, those are a part of this meeting and beyond. We are getting a lot of calls from outside, AP, Karnataka, and name the state, Jharkhand and all that. So we are really struggling with which specimens and how to decide a testing approach. Because for lab also, NIV also, it's very difficult to go about, and we have seen 26 different agents we have tested, including bacteria, viruses, and others. There is still anti-ganglioside antibody testing pending. This is being done at NIMHANS, Bangalore. So again, there are toxicological studies, samples have been sent for chemicals and other. And there are other hypotheses that the experts are putting on in different platforms. So really a need to actually work together for all of us. And I volunteer myself to work with the team that you decide in due course to further take this up, to decide some surveillance strategy, a diagnostic testing approach, algorithm, whatever mechanism Dr. Nagwekar as part of our SAC, Scientific Advisory Committee, and the other experts here. Most of them are in Pune. We would like to have that interaction and go ahead. Thank you.
Sure, Dr. Tanjali will, from Clinical Infectious Disease Society, will definitely participate with you all and definitely help us mutually to see how we can draw algorithm, as you said. I will definitely work with you, and I'll call you once, maybe tomorrow, day after tomorrow. How do we go about doing this?
Vasant, I have a question for you, Bharat, Purandare, Dr. Tandre, and Dr. Bondre, maybe, sorry. So if I used to, do some PhD work before, and one of the things which I believe we can actually look at, because we've got a huge subset of patients now, is if we have a CSF sample, we can actually do a 2D gel electrophoresis and then do mass spectrometry with proteomics to see if there is an upregulation of any proteins in this. I think this will help us to identify the host, that why are some patients more likely to develop uh, GBS than the other people. And we could perhaps have some healthy volunteers donate CSF and see whether there is a similar upregulation or downregulation of these proteins or not. I think this is a fantastic opportunity for this kind of a research. We'll never get 20, 30, 40, 50 patients like this ever again in our lifetime. So if you can actually have the CSF sample, even 1 ml of CSF will be enough to go through the proteome, to the entire 2D gel electrophoresis and then mass spectrometry with proteomics. I used to do that for sepsis around 15, 20 years ago, sir. And it is not very time consuming.
Yeah, yeah.
It would take a dedicated person in the lab to do it. Of course, it requires a little bit of expertise, but it's fairly easy to look at the upregulation of proteins or downregulation of proteins, sir.
Absolutely, sir. Maybe in a day or two, we'll sit together with a group of scientists and we'll discuss. And for any kind of help, if it is required, we'll come back to you, sir.
Thank you, sir.
That's a very, very good thought, Rahul, about looking at why certain hosts. There will be thousands of people who have suffered from this or contracted noro or Campylobacter jejuni, but why only few of them landed up with GBS? I think there's a host factor definitely, though there has been no proper correlation about the host and Campylobacter jejuni, but there is a definitive some immunological, upregulation, as you said. We definitely look at it, and I think we can work with the microbiology department at Dinanath Mangeshkar, and of course our friends Dr. Tandale and Dr. Bondre from NIV Pune to support this. Dr. Bharat is there, Dr. Parikshit is there, and I think we have a neurologist and Dr. Shripad and Dr. Rahul. I think definitely all of us together can look at it and maybe form a team and work it. How can we be going? What do you are in them?
I think we have had very great discussions on the what happened in this recent higher incidences. We learned about the different types, variants of GBS, typical and atypical presentations, or to do a clinical diagnosis, support when to ventilate. We also have had a lot of introspections on who are the usual offenders, the different on the Campylobacter, a very nice presentation by Parth on that. We also know that maybe the tropical fever can also precipitate along with the Noro and Zika, though we didn't have that A. I think we have also an idea that the vaccines can also do, though we have not touched upon that part. Dr. Pandit gave a brilliant idea on that what we can take advantage of this not so warranted situation, but still we can take advantage. Never ever we may not get one more chance to have so many patients together on that part. And we also learned that a good critical care, good excellent supportive and rehabilitative care, barring certain very few incidences of autonomic dysfunction, the patient should not be should not have a demise out of this unfortunate disease process, and 97% of patients will have more or less acceptable outcome, ambulatory outcome of this. So thank you all the panelists, and once again we invite you for the SIDS conference in Mumbai in June, which is being organized by Dr. Vasant itself, and we will come back with certain good program. So thank you all for joining and giving your valuable time. And thank you, Vasant sir, specifically.
Thank you, Dr. Tandale, Dr.
Thanks,
Tandale,
thank you, thanks a lot.
Really.
It was a pleasure to be with you.
Good night, sir.